Let's assume this is ECG paper and each box is one big box, and inside one big box there are 5 small boxes both vertically and horizontally. Each small box represents 1 mm, and 1 mm you know it is equal to 40 millisecond, right? So one big box is equal to 200 millisecond, right? So 5 big box is equal to 1 second. If you calculate mathematically, it becomes 5 big box is equal to 1 second. So if you have seen ECG machine, the paper is folded like this in an axle, right? And the paper rotates like this, and paper goes on moving like this. So in 1 second, this much distance is traveled by the paper. These 5 big box is traveled horizontally in 1 second. If there is 1 second, this much distance traveled. In another 1 second, this much distance is traveled. And while this paper is moving, there is an ink pen that is making a sketch on this paper according to the amount of voltage that is flowing in the direction of the lead. So let's assume this is an ink pen that is making a sketch on this paper. So let me draw another. So let's assume this is an heart, and this is SA node, this is a fibrous ring, this is insulator, and this is right atrium, left atrium, right ventricle, left ventricle. So the current that is generated here is moving in this direction, this direction, this direction to the AV node, right? Let's assume this is the lead 2 that is recording the electrical vector that is following in this direction. So let's assume this is an ink pen, right? And that is in the ECG machine. So when the current is flowing in this direction, in lead 2 it deflects like this, just like this, it is not like this, right? Now the current does not only flow in this direction, it also flows in this direction, because every part needs to be depolarized. So there is so in lead 2 you will not get like only this vector. The ink pen again deflects like this, right? So this makes a P wave, right? Sometimes you might have seen P wave like this, P wave, biphasic P wave, or sometimes inverted P wave, right? So P wave can be, it is not always like this. Sometimes you might have P wave like this, right? Sometimes P wave is peaked. So according to the atrial abnormality, the morphology of P wave changes. That I will discuss in another video. But let's first of all let's talk about normal healthy heart. So the current is depolarizing in this direction, so just one deflection by the ink pen in the ECG machine. Now other part needs to be depolarized, so there is another deflection like this, right? Now the current reaches here, but there is a pause. It does not let all current go to the ventricle directly. There is a pause, delay here, that is atrioventricular delay. So the pen does not deflect now, so you will get this line, isoelectric line. So this is P wave and this is isoelectric line. Now the current travels in the left bundle branch, right bundle branch, and there is a septum, right? This interventricular septum. So the current first of all comes to the interventricular septum, right? And septum depolarizes from left to right. So if you see in the left precordial leads, there is a small Q wave because the current is moving in this direction. So in these sided leads, there is a small negative deflection like this, right? So this, there is one, the ink pen makes the deflection like this. Now ventricle needs to be depolarized. These are the ventricles. So the right bundle branch depolarizes this side, left bundle branch depolarizes this side, but the left ventricular muscle mass is greater than right ventricular mass. So this vector, and if you see this vector, if you sum up, the net vector goes in this direction because this vector is bigger, greater. So since the net current is flowing in this direction, you will see deflection like this. This is not like this. Just see what I am doing. It deflected like this because the current is moving in this direction. So the pen make an sketch like this, right? So this is peak of R wave. Now this anterior portion of the ventricle depolarized, but the posterior part of the ventricle needs also to be depolarized as well, because the current is not just on the anterior part, but it also needs to travel posterior part. So current now moves in this direction to depolarize remaining ventricle, the basal portion of the heart. So since current is moving in this direction, now the pen deflects like this, because this is recording from this point, right? So current is moving in this direction, so the pen deflected like this, right? So now at this point ventricle depolarization has completed. Now everything that occurs from this point onwards is ventricular repolarization. Why I am emphasizing this? Because you might have memorized like P wave is atrial depolarization, QRS is ventricular depolarization, and T wave is ventricular repolarization. So this T wave is not only ventricular repolarization, everything that is occurring from this point on is ventricular repolarization. Like this wave, this wave, this wave, everything is ventricular repolarization. This is not just this portion. That's why if you have seen the cases of early repolarization abnormality, you will see the problem in the hair here. So if you see cases of repolarization abnormality like left ventricular hypertrophy, left bundle branch block, there is depolarization abnormality. So if there is depolarization abnormality, there will also be repolarization abnormality. If the depolarization in the ventricle is normal, then repolarization will be normal like this PQRST. But if the depolarization is abnormal, if left bundle branch is blocked, let's suppose, so the current will normally not flow through this pathway. So current will first of all depolarize this and then will travel like this. So depolarization first occurs in right ventricle and later the left ventricle depolarizes, right? Depolarizes. So repolarization also begins in the right ventricle and later left ventricular repolarizes. So whatever the sequence of depolarization occurs, repolarization follows the same sequence. That's why if you have seen the ECG of left bundle branch block, you might have seen like this. If you see in the V1 lead, there is like P wave and there is a small R wave and big S wave, and it goes like this, like, right? So if it looks like there is ST elevation, but this is not ST elevation EMI, this is just ST elevation due to repolarization abnormality in left bundle branch block. Because depolarization is abnormal, that's why repolarization is also abnormal. If you have seen ECG of left ventricular hypertrophy, there is also the pattern looks like there is ST elevation EMI, but that ST elevation or ST depression has not occurred due to EMI, but it has occurred due to repolarization abnormality, because there is depolarization abnormality because of the left ventricular hypertrophy, because there is more muscle mass that needs to be depolarized compared to normal healthy heart. That more muscle mass might have been added concentrically or eccentrically, so depolarization gets altered. Similarly, repolarization gets also altered. See the normal R wave progression. Normal R wave progression, you know, in V3 V4 leads, the amount of positive deflection and the amount of negative deflection becomes almost equal in V3 V4 leads. If you see V1 V2 leads, there is a small R wave and there is a big S wave, right? In V2 R wave becomes little bigger, S wave becomes little smaller, and in V3 V4 it becomes little almost same, and in V5 R wave increases and S wave becomes smaller, and in V6 R wave becomes little smaller than V5 because this is more lateral lead, and S wave becomes little smaller. So if you see the voltage in V6 is greater than V5, you should be suspicious of LVH, because normally voltage in V5 is greater than V6. And let's say if you see early R wave changes. What do you mean by early R wave change? Like I told you that in V3 V4 this becomes like almost equal, and if you go in V5 then you can see that R wave increases its amplitude compared to S wave. It is R wave greater than S wave is greater than 1 in V5 V6. But let's say if you are seeing in V2 lead, R wave is greater than S wave. Let's say R wave is greater than S wave in V2 lead, or in V3 V4 if you see R wave is greater than S wave, it suggests that R wave is greater than S wave, which is not normal R wave progression. So it suggests that you have hypertrophy. And other criteria of hypertrophy, you know, if you sum up the S wave in V1 and R wave in V6, if it is greater than 35 mm, then that suggests you left ventricular hypertrophy. Another is in AVL lead, if you see it, the voltage is more than 11 mm, it suggests you left ventricular hypertrophy. Other is strain pattern. If you see big voltages in V5 V6 and a big voltage in V1 and there is a strain pattern, that suggests you more towards LVH, right? So the main message of this lecture is that do not assume that ST, if you see ST elevation, it is not always ST elevation EMI. You have to consider many things. So basically ST elevation or ST depression occurs due to problem in repolarization. So repolarization problem can occur due to many factors, like in normal physiological heart also, if you see 100 people, like in 2 to 3 people you can get early repolarization, and that is not hampering him, that is not hampering his cardiac output, nothing. So that is actually normal. So it can be, or as I told you, it can be left bundle branch block, it can be left ventricular hypertrophy, it can occur in pericarditis, right? It can occur in vasospastic angina, it can occur in ventricular aneurysm, it can occur in hyperkalemia, it can occur in Brugada syndrome, it can occur in takutsubo cardiomyopathy, it can occur in WPW, it can occur in aortic dissections. So wherever there is depolarization abnormality, there will be repolarization abnormality, because the sequence of depolarization, because let me rephrase it again, because whatever will be the sequence of depolarization, repolarization will also follow the same sequence, right?